Thank you. Respected Chairperson, and it's always a difficult thing whenever Dr. G. Vijayakumar gives me topics. So I have two topics here. One is adipocyte, and this one is sleep. Now, I'll start off with a very simple thing. This is what we do. In a 24-hour day schedule, all of us are involved with 5 behaviors: sleep, sitting, stepping, sweating, and strengthening. So I'll be talking only one of them today, which is sleep. Now, this is the sleep cycle. It might take you back to your medical school days if you have forgotten the REM and non-REM. I had forgotten, thanks to him, I again studied it once again. But the most important part of sleep is the N3 or stage 3 part of the non-REM sleep. The reason is, this is the most refreshing part of the night, where most of the repair of your cells, tissues, and muscle takes place. So if this part of the sleep is disturbed, you can expect metabolic disturbances to happen in the near future. Now look at those curves. Each REM, non-REM sleep is one cycle. We have repeated cycles throughout the night. If these cycles are disturbed, you might have a good one cycle, but the next cycle is disturbed. It's called loss of sleep pattern or fragmentation. Then you also develop problems. So it's not one sleep cycle which should be good. It should be repeated sleep cycles. So what constitutes a healthy sleep? This is the agenda of my topic. Adequate sleep involves a good duration of sleep, good quality of sleep, timing and regularity, which is circadian rhythm, and what is always talked about, which I will not talk about today, is absence of sleep disturbances like insomnia, OSA, restless leg syndrome, and depression. Traditionally, whenever we talk about sleep, everyone thinks this is what is not talked about of sleep disturbance. Now, suppose you have someone with depression, you treat depression, and the person is sleeping for 9 hours a day, which is the first part. Duration is now disturbed. That's bad. That's not good. So always talking about sleep disturbances won't solve the problem. So I'll start with the first one, which is duration. Quantity of sleep. What is the adequate quantity of sleep? Here, I acknowledge ChatGPT-4. I just typed 2 lines, and ChatGPT-4 gave me this particular figure, which is the risk of conversion from pre-diabetes to diabetes. The adequate sleep is 7 hours. And the range is between 6 to 9 hours. Per hour of sleep, less, which is less than 6, or more, that is 1 hour more than 9, it exponentially increases the risk of metabolic disorders or conversion from pre-diabetes to diabetes. What does it do? Now, in individuals who are already having type 2 diabetes, if you look at the sleep duration, the top part is when you sleep less than 6 hours, and the lower part when you sleep more than 9 hours, you can see that your sugars are disturbed. In those who are getting 7 hours of sleep, has their HbA1c under control. Your efforts will be rewarded. But if your sleep is disturbed, the duration is less than 6 or more than 9, whatever drugs you start adding, you will get at least 0.4% lesser HbA1c reduction. So adequate quantity of sleep is extremely important. This is, I think, the last part of this quantity of sleep slide, but this is extremely important. Now, our diabetic patients also have associated risk factor. A diabetic patient may have associated hypertension, dyslipidemia, family history of ASCVD. So depending on the number of risk factors, you can see here that the hazard ratio is 0 out here, which means as someone who doesn't have any additional risk factor, the hazard ratio, they have only diabetes, so the risk is 1. But the minute you're sleeping more than 9 hours, the hazard ratio goes up to 2.18. Now, if you keep on adding the risk factors, 1, 2, 3, you see the baseline risk has gone up. 1.79 is the hazard ratio. And now you're not sleeping well, and you see that the risk is going up further. So this is an area which probably we do not talk about in clinical practice. We need to be very careful because we are very happy with adding a drug, but not taking history of how good a patient is sleeping or what is the duration of sleep. Now, a patient is sleeping well 7 hours a day. But if the quality of sleep is disturbed, now, quality of sleep is defined as an individual's self-satisfaction with all the aspects of sleep experience. What are these aspects? There are 4 components: sleep efficiency, sleep latency, sleep duration, wakefulness after sleep onset. You must be getting up a lot of the days feeling that you have slept well, snored well, which is a bad sign actually, there's less oxygen in your brain. But traditionally, our family tells us when you snore, you sleep well, when you burp, you have eaten well. But it's not always true. Snoring means less oxygen in your brain. It's probably sleep apnea that you're. So wakefulness is extremely important. How alert are you after waking up from your sleep? Now, these are the factors which contributes to poor sleep quality. It could be environmental. I go to sleep early, but my neighbor loves the rock music, and it's banging on the walls on my door, so that disturbs my sleep. Behavioral, psychological, and importantly, for diabetic patients, nocturnal hypoglycemia is a very important contributor to disturbing your sleep. Now, there are two aspects. One is initiation of sleep. Another is, yes, you go to sleep early, but you cannot maintain your sleep. So these are the two important aspects of sleep quality. So if the initiation of sleep is disturbed, or you see that the maintenance of sleep is disturbed, again, your HbA1c will be higher. So this is an important lesson to understand about the quality of sleep. Now, here's a trend. This comes from the USA. You can see when things were like 8 to 5 hours of work, and then you had those telephones, the only way of connecting you, no mobile phones. See, the risk of diabetes were not that bad. As our connectivity improved, the risk of diabetes went up. And with it, you see that the low quality of sleep also went up. So it seems to be a direct relationship between the poor quality of sleep. And it's getting worsening today with concepts like work from home, night shifts increasing proportionally. Your risk of diabetes is also going up because it increases your HOMA-IR, insulin resistance, contributing to prediabetes and diabetes, and then conversion to prediabetes to frank or overt diabetes. This is the most important slide when it comes to understanding the addition of insomnia or poor quality of sleep with the pre-existing diabetes. So you can look here. If you have diabetes but no insomnia, if you see hazard ratio is 2, but you just add insomnia to it, the hazard ratio is more than 2.5. So you can imagine insomnia as an independent risk factor for not only progression from prediabetes to diabetes, worsening of your glucose control, but also the outcomes of all-cause mortality and CV mortality. Now, third part is this chronotype or the circadian rhythm. There are a lot of terminologies here. I'll just break it down. There are two types, broadly two types of people, two types of sleeping pattern. One is called early bird or lark pattern. One is the night owl, who go to sleep quite late and also wake up late. Now, we have body clocks. The central clock is in the suprachiasmatic nucleus of the hypothalamus, and we have peripheral clock in the sensory part of the body, which communicates with each other. What we call as the disturbance of chronotype is something called the sleep debt. It is the amount of duration of sleep that we need and what we are actually sleeping. The deficiency is called sleep debt. And we have the sleep rhythm, which is controlled, or the sleeping clocks, which are controlled by time givers, which has a German word called Zeitgebers, and neurohumoral pathways predominantly mediated by melatonin. Now, I'll summarize this with this particular slide. This is the 2024 ADA consensus statement on sleep and insomnia. So what you see is, on that end, these are the conditions which actually misaligns your circadian rhythm. Shift work, social jet lag, sleep disorders, disturbed feeding rhythm can all disturb your sleeping pattern. What happens as a consequence is the cortisol goes up in the system, melatonin goes down. As the cortisol goes up, the inflammatory markers go up. So there's more oxidative stress. So the blood vessels are exposed to oxidative stress, pro-inflammatory cytokines, you develop diabetes. In the stomach, there is an imbalance on the appetite hormones. So you find there's imbalance between ghrelin, leptin, and adiponectin. And in the pancreas, you have insulin resistance and conversion to type 2 diabetes. And now what you do is you do defense in snacking. When you're not sleeping well, you snack. So there is obesity, enhanced lipolysis, more free fatty acid into the system, ending in depression, anxiety, poor quality of life. The whole cycle can be taken care of by these particular types of therapeutic options, but these are the causes of your misalignment. I'll just stress upon one part of the misalignment, night shift. Again, this is the modern day bane of advancement, night shift and work from home. There's no timing, right? People out here who are working on the US times, the complete circadian rhythm is misaligned. Now, there are three types of chronotypes. One are the late chronotypes, who go to sleep late, but the most productive in the late afternoon. The early chronotypes, who wake up early in the morning, most productive in the early hours of the morning, and intermediate ones, who are most productive in late morning and early afternoon. So if you put someone who is not used to a shift work and ask them to do a night shift work, there is a 10% increase in conversion from pre-diabetes to diabetes. But it's very interesting. This slide, I think, is the most interesting slide I've prepared. Now, someone who is not doing any night shift, but goes to sleep early, has a less chance of converting from pre-diabetes to diabetes. But one who goes to sleep late and has a disturbed circadian rhythm has a high risk. There's no brainer out here. But see the interesting part. Someone who is already late sleeper, and you put them on a night shift, so he's already malaligned circadian rhythm. What more will you malalign? There is no increased risk. But rather, who is an early sleeper, and you put that person on a night shift, look at that, 63% increased risk of the risk of developing diabetes. So this is an important history that we need to take and understand, that always blaming someone going to, probably a guy who's going to sleep at night will be much more happier doing a night shift, or will be less disturbed compared to the baseline. But someone who is going to sleep early will be more disturbed if you put them on a night shift. 3 important aspects, busy slides, just 3 lines. What constitutes a significant misalignment of the circadian rhythm if it is delayed by 90 minutes on either side of 6 to 9 duration of the cycle? So 90 minutes is your cutoff. More than 90 on either side of the 7-hour sleep is going to create a problem. The increased risk of cardiovascular disease comes when there is a disturbance of sleep synchronicity. And if there's sleep fragmentation, you're waking up very frequently. It happens with benign prostatic hypertrophy or frequent hypoglycemia at night. Then there's increased risk of mortality. Now, how do we measure sleep? This is the most controversial area, and the consensus statement didn't give any conclusive answer. Polysomnography is exclusively used for OSA, but it should be used more in quantifying the quality and quantity of sleep, because this is probably the most accurate method of quantifying sleep, in contrast to many other apps or tracking apps that we use nowadays. Now, many interventions are there: cognitive therapy, sleep education, melatonin, CPAP. This is the summary of all the treatment. There are 2 types of cognitive behavioral therapy. One is for anxiety and one is for depression. They're 2 different. And CBT, as you can see, can help in reducing HbA1c by 0.43% and also improves quality of life. Same thing with sleep education, but not so with CPAP. CPAP can help in having a good night's sleep, but has absolutely no evidence that it does anything to the outcomes. So something extra needs to be done in OSA, and that extra is weight loss. That's the best therapy. So just putting a CPAP won't make much change on the outcomes. Melatonin also, when you're traveling, there's a risk of jet lag, you use it, but outcomes benefit, there is nothing. The disturbance that you have on a jet lag related to your metabolic disturbances or conversion from pre-diabetes to diabetes, that risk remains, it doesn't disappear. I'll end with this very recent study. It has nothing to do with diabetes, but I thought I'll show you. These are NBA players in USA who are traveling from one coast to another to play. Who are the better performers? Quiz. The best performers are the one who are playing at home. Those who are going for an away match are losing 63 points in the whole season. So you see, this is what a practical example of what disturbance of circadian rhythm can do. So summarize, again, this is the ADA consensus, which summarizes everything that I said. Important is duration of sleep, target 7 to 9 hours. 85% of that time you should actually be sleeping. This is the quality of sleep. And target for at least that the social jet lag should not cross 90 minutes. Identify these individuals and take help from clinical psychologists or educators for cognitive behavior therapy or for sleep hygiene. You know, the blue light of the mobile phone, reading a book and going to sleep is a fantastic thing. But the mobile phone blue light completely disturbs your sleep. So that's something which is a no-no. So this is called sleep hygiene, which has to be taught to our patients. Thank you very much.